Everyone. My name is Lily Liu, and I'm the Dean of the Faculty of Health here at the University of Waterloo. Welcome to you all. It's my great pleasure to start this conference on aging, COVID-19, and the adoption of health technology. This event is a collaboration between the Faculty of Health's School of Public Health and Health Systems, University of Waterloo's Network for Aging Research, and the Faculty of Engineering's Center for Bioengineering and Biotechnology. We are very, very pleased to host a local, national, and international audience today. COVID-19 has provided an unexpected benefit of extending our reach through the use of technology. I'd first like to begin with a territorial acknowledgement. As the host organization, the University of Waterloo, with its campuses in Waterloo, Kitchener, and Cambridge, are situated on the Haldimand Tract, which includes 10 kilometers on each side of the Grand River and within the territory of the neutral Anishinaabe Haudenosaunee peoples. Those of you located across Canada are situated on different Indigenous territories throughout Turtle Island. We acknowledge the diverse Indigenous peoples whose footsteps have marked these territories for centuries, and these footsteps will continue into the future to guide us on paths with Indigenous wisdom. I also welcome our international participants who reside in parts of the world also with rich histories. This afternoon, we're hosting 2 Hallman panels as part of the Faculty of Health's ongoing Hallman Lecture Series. The Hallman Series explores the Faculty of Health's commitment to excellence by bringing timely and topical learning opportunities to our broad community. They are made possible by a generous legacy gift left to the University of Waterloo by Lyle Hallman. Lyle was committed to making a lasting difference in his home community of Waterloo region. This difference is realized by supporting local organizations to foster relationships that lead to resilient, connected, dynamic, and creative communities. The funding that the University of Waterloo has received from Lyle and his wife, Wendy, has empowered our faculty to make strides towards our vision of protecting and promoting health and well-being for individuals and communities, both locally and across the globe. We are very proud to share the vision with the Hallman Foundation to optimize health, prevention, and we're pleased to acknowledge and show our gratitude to the Hallman family for their leadership and support. In keeping with this legacy, research and care for seniors has been a long-standing priority at the University of Waterloo. We have a breadth of disciplines that help us to better understand and support individuals as they age. This 2-day forum represents that breadth as we explore the impact of the pandemic on many aspects of the aging process, from bedside clinical care, extending to community care, including health providers, policy and practice, and information systems, as well as the use of technologies. And now onto our distinguished speakers in a program that's relevant to the issues we face in 2021. First, the international panel will give their perspectives on COVID-19 and older persons. Dr. Graziano Onder from Italy, Professor Anja Declercq from Belgium, Dr. Geffen from South Africa, and Professor Terry Lum from Hong Kong. Professor Chris Perlman from our own Faculty of Health will be the panel moderator. After the break, the second presentation will begin about the pan-Canadian impact of COVID-19 on older adults. We will be joined by Dr. Andrea Fobo from the Canadian Institute for Health Information, Professor Jennifer Walker from Laurentian University, Professor Carrie McKaney from our Faculty of Health, Executive Dean Veronica Boscart from Conestoga College in Waterloo Region, and Dr. Vivek Goel from the University of Toronto, who is also President and Vice Chancellor Designate of the University of Waterloo. Our second moderator will be Dr. Nicole Mercer, who is Chief Executive and Medical Officer of Health of the Wellington Dufferin Guelph Public Health. The panel discussions will highlight the importance of health and safety considerations for seniors, with a focus on how we protect them and their caregivers from COVID-19 and how we help them live fulfilling lives in the face of a pandemic. We have learned that COVID-19 presents complex issues when it comes to planning for staffing and service delivery. Our healthcare system has been faced with the question of how to provide effective services that support older adults with complex conditions amidst the need of infection control, social isolation, and increased capacity for hospitalization. This pandemic has forced us to consider ageism in the face of COVID-19. In the 2020 Lancet paper, Eva Marie Kessler and Catherine Bowen suggest that, quote, as a result of COVID, ageism, not only older people, but also younger people are at risk of internalizing the representation that being older means being vulnerable, is associated with worse trajectories of physical and mental health with time. Today's conference will help us unpack our assumptions in the realities about care for older adults during this pandemic and beyond. I would like to extend a sincere thank you to all of our staff and faculty members who organized this collaborative event between the School of Public Health and Health Systems, the Network for Aging Research, and the Center for Bioengineering and Biotechnology. We are so grateful to you for putting together such an exciting virtual conference that reaches across the globe. At this time, I will introduce the moderator of the first panel, Dr. Christopher Perlman, who is Associate Professor in the School of Public Health and Health Systems and a Fellow of INTERI. He's interested in how we use data to improve our health system for persons living with mental health and addiction conditions across the lifespan. Recently, he's led a study that examined patterns of psychiatric hospitalizations among persons with dementia and their access to psychiatric care and long-term care nursing homes in Ontario. Chris?
Thank you very much, Lily, for that wonderful introduction to this conference. It's truly amazing. Some months ago, when we began planning for this conference, it was really difficult to consider where we as a society might be in relation to the pandemic, and it likely still is. But one thing that's for certain is that this pandemic has shown us just how much more work is needed to honor and protect our seniors, as well as those who care for them in formal and informal ways. And so to this point, I'm very excited to be able to introduce you to 4 people who really truly value that ethos. Interestingly, I had the good fortune to get to know our international and several of our Canadian speakers as fellows of the INTERI Research Network. And in fact, just last year, in early February, Professor Declercq and her colleagues were hosting the World INTERI Conference at the renowned UZ Leuvin Hospital. It was a time when COVID-19 was just reaching the public lexicon in early February. And we spent time over our meetings and at dinner sort of discussing what might be at stake, particularly for older folks in our community and residential settings. And really, walking through the bustling, bright foyer of the hospital each day, it was really impossible to really imagine how deeply this hospital and so many other care settings would be impacted in only a short time after our departure. And so to help us understand these circumstances further, I'm delighted to introduce our international panel. We have 3 live presentations and 1 recorded presentation from Professor Terry Lum that you can review outside of the program at break or at breakout session times, as well as following the conference. Following the presentations, we will have time for questions and discussion. So first, I'll quickly introduce Professor Lum, who has recorded his presentation. He's from the University of Hong Kong. He's the Henry G. Lung Professor of Social Work and Social Administration and head of the Department of Social Work and Social Administration at the University of Hong Kong. So again, due to the time differences, Professor Lum has been so kind to pre-record his presentation for your viewing. What's amazing about his presentation, and I hope you'll have a look at it, is that Hong Kong had a real success story through this pandemic. And much of that was due to their learnings, both from the SARS pandemic of 2003 and the implementation of really early prevention measures. Now I'll turn it over to our live panel. Our first speaker this afternoon is Dr. Graziano Onder. I first met Graziano actually at an Interi meeting in Toronto, and I had the pleasure of introducing him to Toronto's Jurassic Park, which, if there's any basketball fans out there, will know that this is the sort of outdoor gathering space for fans of the Toronto Raptors. And so Graziano and I had a great time watching the game and discussing basketball. But in addition to being a basketball fan, Dr. Onder is a renowned geriatrician with the Italian National Institute of Health and associate professor of the Catholic University of the Sacred Heart in Rome, Italy. He has a strong track record of very high impact research with expertise in pharmacoepidemiology, chronic disease, and elderly care. And currently, he's recently received a huge multinational grant from the European Union in the amount of close to $9 million Canadian to study the quality of home and nursing home care across a number of countries, including Canada, where John Hurdy's and George Heckman are collaborating. So with that, I'll turn it over to Dr. Onder, who will share a presentation on causes of death and risk factors for COVID-19 mortality in Italy.
Thank you very much, Chris. Thanks for a very nice introduction and for inviting me here today. So I will share my screen, and I hope you can see my slides. So please, Chris, confirm that you're seeing my slides. Are you?
Yes, I am. We're seeing them in the full presentation mode.
Okay, thanks. So I will focus mainly on causes of death and risk factors for COVID-19 deaths, bringing you some Italian data that probably are confirmatory or in line with what you have observed in Canada. So during my presentation, I will try to focus on several risk factors for COVID-19 mortality, moving from age to chronic frailty and disability, dementia, and obesity. And at the end, I will present some data based on death certificates review in order to show that most persons dying with SARS-CoV-2 positive testing died because of COVID-19 and not other causes. So let's move from the first risk factor I want to talk about, which is age. So it is very well known that age is the strongest risk factor for mortality in the population due to COVID-19. On the top left corner, you see data from the Italian population with the absolute numbers of deaths by age group. And you can see that the age groups of 70 to 79 and 80 to 89 are those with the highest number of deaths. The other graph or the other table shows some data we have published at the beginning of the year, showing that case fatality rate progressively increased with increasing age. And this was true in Italy, and we compare with the only other data available at that time that were data from China. But I want to bring this evaluation more in depth, looking at a parameter that we are assessing constantly in Italy, that is the excess mortality. The excess mortality is the number of deaths from all causes during the pandemic, during the year 2020, as compared with what expected under normal conditions. So with the average number of deaths in the 2014-2019 period. As compared with the average from 2014 to 2019, in Italy in year 2020, we have 100,000 deaths more, meaning about 15 to 20% of deaths more than what observed in average in the former 6 years. But we also analyzed this data more in depth, looking at age groups and looking at different periods of the year. So the percentages you see reported are the excess, the increment, if they're positive, of decline in mortality as compared with the same period, with the average of the same period of the years 2014-2019. So there are some data I would like to underline. First of all, an increase in excess mortality in the age groups 50 to 80 plus, 50 or older, basically. I mean, those 80 plus or older had an increased excess mortality rate increased by 36%. But this increase in excess mortality can be also seen in other age groups. Another important datum that really struck us when we started to analyze this data is that before the beginning of the pandemic, January and February 2020, we had a decline in excess mortality, decline in mortality as compared with former years. Reason for these findings are not completely clear. This is probably due to the fact that the influenza season was not as strong and as bad as it was in the former years. But clearly, we observed a reduction in mortality in this in the first two periods of the year. And the other striking result is that when we look at age group 0 from 49, we saw that overall in 2020, this age group had a decline in mortality. And this is probably due to the fact that most of the mortality in this group is due to car or motor vehicle accidents, and these were strongly reduced during the lockdown period. So this further underlines how the impact of the pandemic was very strong, was the strongest in age group 50 to older, and particularly 80 to older, where those younger than 50 had somehow a benefit in terms of mortality from the pandemic, probably more from the lockdown that was the consequence of the pandemic. After I want to show you some data on chronic disease, multimorbidity, and frailty, which are very common conditions in older adults and are strong risk factors for COVID-19 mortality. So I'm presenting here some data from chart review of people dying with COVID-19. So I'm coordinating at a country level a group that is reviewing charts of people dying with the disease. So we centralize charts coming from hospitals throughout the country, and we analyze them. Actually, we analyze a representative sample of about 10% of overall deaths. And as you can see in this population of persons dying with COVID-19, prevalence of multimorbidity was extremely high. Overall, 60% of these persons had 3 or more diseases. Again, these are people dying with the disease. And 60% of them had 3 or more chronic pre-existing diseases. And this was true both when we look at those 65 or older, the prevalence is more than 60% of 3 or more diseases. But also when we look at the younger population, meaning younger than 65 years, so about 43%, 44% of them had 3 or more chronic conditions. No distinction among chronic conditions, hypertension, diabetes, neurological diseases, and so on. We also looked more in depth at complications as a consequence of the infection, meaning complications that led these persons to death. And we also found some interesting data when we look at these complications. We mainly analyze 4 complications: acute respiratory distress syndrome, acute renal failure, acute cardiac injury, and superinfections. These are consequences of the infection. And what we observed was that non-respiratory complications were common, but they were more common in younger adults than in older adults. And so the message here is probably that older adults are more likely to die of these conditions, probably because they have a higher vulnerability due to pre-existing diseases. Younger adults are less likely to die, and they die when a non-respiratory complication comes in the clinical picture. Also, as I said, frailty is another important factor that may influence mortality in this population. I'm sure you're aware of what frailty is. It's a vulnerability. It's a condition that increases the risk of adverse outcomes. Most of the time, it is measured by performance measures. This specific scale that I'm presenting here, which is the clinical frailty scale, is based on a very simple scale developed in Canada, actually. And it's based on physical function. These data are not from Italy, but this is a country study that is showing that as the clinical frailty scale score increases, which means higher level of frailty, well, the mortality risk increases. We also have some data from an Italian sample of hospitalized patients in Brescia in northern Italy, where we show that this same scale, the clinical frailty scale, has as measured, as assessed before admission, has a very strong predictive ability in terms of mortality. You can see the area under the curve for frailty is 0.86. And the one for multimorbidity is only 0.76. So this clearly means that frailty can better predict mortality in COVID-19 patients better than multimorbidity. And also we put these two scales together, these two factors together. And we looked at survival in patients with COVID-19 as in those that didn't have either frailty or multimorbidity, in those with multimorbidity only, and in those that had multimorbidity and frailty. And so as you can see, this latter group is the one with the highest mortality. So this clearly underlines that beyond chronological age, there is a biological age that clearly impacts on survival in this population. Also, a very last issue related to frailty, because we usually think of frailty in the geriatric context, but this is not the case, because also young adults may have frailty, and this is the case of adults with Down syndrome. I'm very proud of this article because based on this, we change our policy, our vaccination policy in Italy. Because we show that adults with Down syndrome had a 10 times greater risk of dying of COVID-19 than the general population. And based on this study, we decided in the country to give priority for vaccination immediately after health personnel and nursing home residents to people with Down syndrome, because it seems they're particularly frail and at risk of negative health conditions and mortality due to the infection. So the concept is frailty is not only an issue of older adults, but also might be something that can be found in younger adults. Dementia is another condition that we commonly see. Please consider that in Italy, we have about 1 million persons with dementia over a population of 60 million people. So about the prevalence in the population is something less than 2%. But when we look at data of people dying with COVID-19, almost about 15–16% of them had dementia. So this clearly underlines that this is a risk factor for mortality in this, at least in our country. Last but not least, obesity, because this is something that a risk factor that is very well known, but I would like to underline something on this risk factor, because we know that obesity is a risk factor for negative outcomes because it may impair ventilation, it may limit the diaphragm excursion, limit immune response, increment inflammatory response. And this is very well known. These are not our data, but are data from published in the Lancet some time ago. But you know, in geriatrics, we have what is called reverse epidemiology. And when I analyzed the data of people dying with COVID-19 according by age group, I was very surprised to see that obesity was highly prevalent in those younger than 65, but much less prevalent in those that were 65 or older. So we thought that there might be a sort of reverse epidemiology also in COVID-19, where obesity is a risk factor mainly for younger adults more than for older adults. And to confirm this theory, we looked at non-respiratory complications leading to death in COVID-19. And we analyzed the association of obesity with non-respiratory complication in the groups younger than 60, the upper part of the figure, and in those 60 or older. So when we look at non-respiratory complication in those younger than 60, we found that obesity was associated to a 2 times higher risk of acute renal failure and shock. But when we look at the same outcomes in those 60 or older, we saw that this association was much weaker. And so probably this may confirm how the concept of reverse epidemiology and the fact that obesity is probably a stronger risk factor, at least for non-respiratory complications, in younger adults than in older adults. Finally, a very final consideration on what was a big discussion in Italy, at least in my country, because looking at this list, age, chronic diseases, frailty and disability, dementia, many persons in the country thought, okay, but these people dying for COVID-19 are very frail and complex population. They would have died anyway. It's not COVID-19 that killed them, but probably their burden of diseases and frailty they're bringing on. So for this reason, we analyzed death certificates of a representative sample of 5,000 people dying with SARS-CoV-2 positive test in the country. And the main question was, okay, are these people really dying because of COVID-19? What are certifying physicians writing in their death certificates? And in all 90% of cases, cause of death. So basically, this confirms that the concept that they would have died anyway is not true, and these people really died because of this condition and because of this disease. Just a very final slide on something we have analyzed yesterday. I told you that the vaccination campaign in the country started in December 2020, and nursing home facilities had the priority in vaccination. So this data shows the number of cases since the beginning of the vaccination campaign, the vertical bar, in nursing homes, the black line, and in the general population, the dots line, the red dots line. And as you can see, while in the last 3, 4, 5 weeks, while the number of cases is increasing, we are now in what is called the third wave here in the country. The number of cases are increasing in the general population. These are declining, strongly declining in the nursing home setting. And this is probably due to the fact that the vaccination is working, and that probably these people are protected, that are the frailest, and probably also the least studied by vaccination studies, are effectively protected by the vaccine. So I'm sorry, I probably talked too much, but basically these are my conclusions. Probably some data are in line with what you saw in Canada. Age, older people are those that got the worst consequences of the infection. Younger people, younger adults were probably somehow protected by the lockdown period, and the mortality in this group was reduced. Frailty, multimorbidity, chronic conditions, and so biological age was a strong risk factor, more than probably chronological age. And really, the vaccination is the only way out in these conditions. So I have showed you how this is effective in the frailest and most complex patients, that are those that are living in nursing home. So thank you very much, Chris, and I give you the floor.
Thank you very much, Graziano. That was a really fabulous presentation, that very eye-opening in many ways, that we need to look beyond the numbers of age and look at what's really going on with a person, I think, in terms of understanding their risks and so forth. So I'm looking forward to having more discussion following the presentations. So our next speaker is Professor Anja Declercq from KU Leuven in Belgium. So in keeping with our theme of, how I got to meet Anja through Interact meetings, I've had the pleasure of meeting her both in Canada and several times in Belgium, where she's kindly shared her culture. And what was interesting to me was her personal connections to a really wonderful group of blues musicians as well. So it's just so thankful for those times. I also understand that she was once a contestant on Belgium's version of Jeopardy. So I also know that it's not a good idea to go up against her in any trivia competitions. But more importantly, Professor Declercq is a very accomplished professor of sociology and is the head of Elder Care Research Unit at the Lucas Center for Care Research and Consultancy at KU Leuven, which is one of Europe's oldest universities. As the national lead for Interact in Belgium, Professor Declercq has also done extensive high-impact research on the use and application of health assessment systems for the care of older adults in Belgium and across the EU as well. And much of this research is focused on the organization of care for older persons, quality of care and quality of life for older people, and the analysis of societal changes that have had an impact on older people and the care that they need and receive. So I'm really looking forward to your presentation, Professor Declercq, and I'll turn it over to you.
Thank you very much, Chris. You know more about me than I knew. I'm going to try and share my screen as well. And I'll try and tell you a couple of things about what is happening with COVID in Belgium. I hope you can see my slides.
Yes, we can. Thank you.
Yeah, okay. Well, we had unfortunately about 837,000 cases on a population of 11 million people. So Belgium is quite heavily affected by COVID, and we have over 22,000 deaths. On Monday, that was it. I'm afraid we still have about 40 people dying every day now of COVID. So the number is still increasing. Just as in Italy, we're in wave 3 at the moment. The government this morning decided to close the schools again next week. We are not allowed to travel unless there is an emergency, etc. Non-essential shops are closing again. We're still in the midst of this pandemic. Don't worry about all the Dutch in the slides. I'm going to get you through it. This is the number of people who were reported, the reported deaths because of COVID and where they died. The first, the top ones is hospitals. You can see Belgium has 3 regions and 3 languages. Flanders is the first one, that's Dutch speaking. Brussels is bilingual. Walloons is French speaking. And then the last columns are about Belgium as a whole. And you can see that about 58% of people died in hospital, and 41% died in a nursing home. In Flanders, where I live, it's even 48%, I'm sorry. And at a certain point in time before vaccination, I'll come back to that. It's very similar to what Graziano showed before. Before vaccination, it was over 50%. So people in nursing homes have been very majorly affected by COVID and represent about half of the people who passed away because of it. Also similar to what Graziano showed, according to age, the dark green is male and the lighter green is female. You can see that most of the people who died in Belgium because of COVID were older. Most of them in the 75 plus category, and many of them in the 85 plus category, which is the average age of people in nursing homes in Flanders is around 87, 88 years of age. So these represent many residents of nursing homes as well. So why the high number of casualties in our nursing homes? Well, because of the reasons that Graziano just mentioned. They're a very vulnerable population. We have an extensive system of home care, which means that people stay at home for as long as possible. And it's also promoted by government to keep people at home for as long as possible, which makes that once they move to a nursing home, they have high care needs and they fulfill all the criteria that Graziano just showed for people who are at very high risk of dying of COVID. The average stay is only 1.5 to 2 years anymore. And so only people with high care needs. So that's factor number 1 for why they were so heavily affected. But there were a couple of other things that unfortunately were more controllable and weren't controlled and still had a major impact on what happened in the nursing homes. And the first one is that our governments focused mainly on hospitals during the first wave and a bit still in the next waves. At first moment, all focus was on keeping our intensive care units running and not making sure that they weren't that there weren't any people who weren't able to go into an ICU, and they forgot a bit about the nursing home population and the fact that those were very high risk people. So during that first wave, the nursing homes were at a certain point in time closed, but maybe just a little too late. But also all the materials that they needed to take care of people in the nursing home when they were infected weren't there. It took quite a while before they had tests. It took, at a certain point in time, they were even asked to give all their materials for infection control to the hospitals, not taking into account that they needed it themselves. And so that was certainly a very sore point and a very painful thing during the first wave. We also have a complicated state structure. We may not be the only country in the world that has that, but part of our health system is a federal responsibility, and part of our health and welfare system is a region responsibility. And so the hospitals are federal responsibility, but the nursing homes are regional. And so Flanders and the Walloons in Brussels and a small German-speaking community are responsible for the nursing homes. And it took a while before they all were on the same wavelength, and everybody was doing the things that were needed for keeping people in nursing homes safe. A third factor, and I'll go into that a bit further later on in this presentation, is that our nursing homes have been historically underfunded. They receive, in part, they receive money from government subsidies based upon the care level of the residents, but that doesn't really represent the care level. It's not enough. And most nursing homes have extra staff, which the nursing home residents themselves pay for with a daily fee, because it just isn't, the funding just isn't high enough. And that, of course, made that they didn't have enough staff to take care of all those people who became sick. Put a lot of pressure upon staff. I'll get back to that too later on. And something that has been indicated for years now became very clear, or even clearer during COVID. The reason for that underfunding, in part, is also ageism. There has been underfunding for facilities for people with, for example, for children with disabilities as well. But the general public has made more noise about that and pushed the politicians more to do something about that than the general public has done that for people who are older. There is some kind of idea that perhaps they already had their lives and that it's not that important anymore. And I think that COVID made that painfully clear, and that it has high consequences then for the people who live there. But there were also a good number of good things that happened. When the nursing homes got into trouble, we saw that the integrated care that the governments are trying to establish for years now and didn't really work, now does work. The silos that we have between hospitals, nursing homes, home care were kind of overcome, and people from home care came and helped in the nursing homes. Also, geriatricians from hospitals came and helped, and we had more integrated care than we usually do in non-COVID times. We also saw a lot of leadership from many nursing home managers, unfortunately not from all, and here and there we saw some disasters happening, but many showed a lot of leadership and worked very hard to do the best they could. And then we saw the general public also stepping in. For a long time, everybody hung out white flags for care staff, but also many people cooked for the nursing home staff. They brought, you can see a picture there of Neuhaus, which is one of the major chocolate factories, that they brought chocolate to the staff and residents of a nursing home. Leonidas, also quite known, gave around Easter last year, gave thousands of Easter eggs, chocolate Easter eggs, to the nursing home staff, etc. And we also saw a lot of creativity from staff to diminish the loneliness of during the lockdowns and to make contact possible in other ways. We saw a lot more video calling, but also creating safe places where they could meet with enough distance, could meet a relative, window visits, concerts in the garden that were organized, and also a lot more activities with the residents, just to make sure that they wouldn't feel alone and lonely all the time. But there also was negative press and there were negative opinions. One gerontologist wrote a couple of opinions in nursing in major papers about the need to just abolish nursing homes and to keep everybody at home, which I think is maybe an idea to think about, but is not something that is feasible for most people. When we look at the population that is in the nursing homes now, that those are people who need 24/7 care, and without informal carers and maybe several informal carers, that doesn't seem to be possible. Moreover, I don't think we have a full view yet on the consequences of COVID for people with heavy care needs at home, but we do have some indication that there's a lot more pressure on informal carers, and that many of them became sick themselves. A lot of anguish as well, fearful of infecting the person they took care of, less people to share the care with, and also less stimulation for people who needed that in their home. Some less home care at points as well, which meant that they declined in ADLs and IADLs, and also in well-being in general. So that's not really an option, I think. Also, there were some complaints from Amnesty International that the nursing homes were in what they call the dead corner. It's what you have with a mirror on a truck, and you can't see some of the people standing next to the. When you're in the truck, you can't see people in a certain corner, a dead corner. Well, they complained that the rights of people in nursing home, the civil rights, weren't met, and that that their wishes were not taken into account sufficiently, and they were not taking sufficiently care of because of the reasons I just mentioned before. There is certainly underfinancing, as I said before, and that also had an impact on staff. There was a survey, self-selected, so maybe not probably not representative, but a survey filled out by over 3,000 carers, professional carers, in December of last year, and 56% of them felt exhausted at the time, as compared to 38% in pre-COVID times. 51% feels high pressure versus 34% when there is no COVID. 46 versus 27% feels they cannot relax. 40% suffers from lack of sleep, and 26% had problems to concentrate. So even though you can see that the numbers are high even in pre-COVID times, too high, but they became even higher. And what we see now after over a year of COVID, is that staff is becoming ill, that nursing home organizations have trouble finding enough people to give the care because they were overburdened. We also saw more physical problems, more headaches, more stomach aches, etc. So government did realize that, and in the second wave, and now a lot more account has been taken of people in nursing homes and their staff. And one of the things that happened is that at the end of last year, there was an extra budget was made available, called a social pact, made available for all care organizations, but a large part of that went into the nursing homes. People working there get an increase in their wages from between 2% and 6%. And there also is a budget for extra staff, which, when you look at it, will still not be sufficient, but at least there is a start of doing something to problems that existed far before COVID, but were highlighted by COVID and had unfortunate effects. There also were people who came in and voluntarily helped. A number of psychologists go into nursing homes to be available for staff who need to talk and to share experiences, and that also certainly helps a lot of people. But on the other hand, we also have a lack of people studying to be a nurse or other care professionals. And so there always are a lot of job offerings for nurses and nursing assistants for nursing homes. And we are a bit afraid that the negative press and the negative consequences of COVID may not be very motivating for young people or for people who want another career to choose a care profession. And even if government were to finance more people in care, we may have a problem in having enough people with the degrees necessary to be able to give good quality of care. So as to policy and politics, nursing homes have felt left out and forgotten, certainly in wave one, but also a bit after. And there was a lot of panicky policy with regulations changing every week. One nursing home manager told me he had over 18 changes in policy, letters from policymakers saying that they had to reorganize in this way or in that way or still another way. But every week there was something new. And in some extreme cases where the leadership in the nursing home was not that good and was unable to follow all those changing regulations, army staff came in to help in those nursing homes. Of course, the medical part of the army, not the infantry or anything like that, but some places were real disaster areas. And then in the vaccination strategy, like in Italy, I think the policy and politicians try to compensate for the fact that they had realized too late that nursing homes were very much in trouble with COVID, and priority was given to nursing home residents and their staff. And then after them, the hospital and home care staff were vaccinated. It started in January of this year. So a very high percentage of nursing home residents now is vaccinated. I think about 98%. And we also see, like Graziano showed in Italy, that deaths have decreased majorly since. At the moment, the vaccination is going on for people 85 and over. It's going really slow because of a number of problems with delivery of vaccines, and also the organization that didn't go very smoothly as well. But vaccination is done now by age group. What we do see and what is problematic is that, especially in Brussels and the French-speaking part of Belgium, there are quite high levels of refusal to be vaccinated by staff from nursing homes. And there has been some call to oblige them to be vaccinated, but at the moment, the nursing homes themselves and policy tries to motivate them with information. But in some nursing homes, there is over 50% of staff not wanting to be vaccinated, which really is problematic. What is also problematic for people who are in home care is that the vaccination is organized in vaccination centers for a couple of municipalities together. So people have to go there, and there is no really good strategy yet for people who are too vulnerable to go there and not sufficiently mobile or not having anybody to bring them there. That hasn't been arranged for yet. It's also not very clear at the moment whether new nursing home residents, people who want to go into a nursing home now, whether they can be vaccinated in the nursing home or have to go to those vaccination centers first. That too, yes, there still are a few hurdles to be solved. You see the number of people vaccinated here as well. The top line is people having at least one vaccination, which is now about 1 in 10 Belgians. And the dark green line is the people who had their full vaccination if they needed 2 doses, depending on the type of vaccination they got. And just as in Italy, you can see that these are the numbers of people in nursing homes dying from COVID over time. And you see that even though we also are in wave 3 with increasing numbers of people being admitted to hospital, being infected, admitted to hospital, and passing away, the number of people in nursing homes who passed away from COVID in the last weeks have drastically decreased. Ageism also was shown in the fact that there was no representation of older people in all those policy changes. We could understand from wave 1 when the nursing homes were really closed, I mean, they closed them up and nobody could visit anymore. At that point in time, that probably was necessary. But after that, in wave 2 and wave 3, there still has been no voice for the residents themselves in whether they may choose to want to be safe and not see anybody, or are very limited number of people, or whether for that last 1.5 to 2 years of their life, they may want to take the risk and see family. In that case, the nursing homes would be having to organize themselves around having different groups of people who want to be really safeguarded, and groups of people who do want to see their family and friends and take a little risk, but of course would not be infecting other people. At the moment, in our nursing homes, with about everybody vaccinated, they still can only see 2 visitors and always the same people. So if you have 3 children, you can only see 2. And there are still many restrictions, even within the nursing home, for activities where groups cannot mingle, for example, which is, if you take into account that they're all vaccinated, a really strange thing. And I think Well, for part of the reason may be that they want to protect the people who visit to be infected, because you can be vaccinated and still infect somebody else, but not be affected yourself. But on the other hand, I think the quality of life of the people in the nursing homes still is suboptimal to what it should be. And so what happens now? Well, this may be a momentum for change. Maybe we will have a major increase in financing. We may have more integrated care, and we may evolve to smaller nursing homes with smaller units where people can choose what kind of unit they want to live in. But there also are some dangers. There are also voices for more re-medicalization of nursing homes and turning them into types of hospitals again, which is something that we want to avoid. They're called, in Flanders, they're called woonzorgcentra, which, if you translate it literally, means living care units, and the living comes first, and the care is something you need, but you have to have a high quality of life. In a hospital, that's kind of difficult, I think. The image of nursing homes, which isn't very positive, may even become more negative, and people may, who really need a nursing home, may wait far too long before going there because of that. And maybe people will also not choose a profession there because of the negative image. And there also may be a danger of over-regulation and not giving some leeway for nursing home managers and their staff to organize the care in a good way with good quality without too much regulation from government. We'll have to see. I'm not sure what will happen in the next months or in the next year, but I am pretty sure that there will be more talk about nursing homes and how we can make them better in Belgium. And I'll have some. I suppose you will receive the slides. I have some links with things you may want to read afterwards as well. Thank you very much for your attention.
Thank you very much, Anja. That was a really wonderful and thoughtful overview of such a complex circumstance. And I think the concerns you're outlining for, what beholds in the future is very important for all of us to consider. So we look forward to discussing that further in a moment. But first, we'll have our third presenter, who is Dr. Leon Geffen. Now, Dr. Geffen wears many hats in his professional life that I'm aware of. One that I wasn't aware of, but recently became aware of, was his affinity for fine food. And such an affinity that it was not just a hobby, but one in which it afforded him, in a prior life, a formal role as a food guide for many of the finest restaurants in the world. So I've learned from that I definitely will not be cooking for Dr. Geffen in any time in the near future. But that said, as I said, Dr. Geffen wears many professional hats. He's a family physician in Cape Town, South Africa, and the director of the Samson Institute for Aging Research in Cape Town. Also an honorary lecturer, senior lecturer in the geriatrics unit at the Faculty of Health Sciences at the University of Cape Town. He's been a contributor to the World Health Organization Clinical Consortium on Healthy Aging, and been part of the expert panel to the WHO COVID-19 infection prevention control guidance for long-term care facilities. He's advised the Western Cape Province Department of Health in South Africa to develop an action plan for older persons during the COVID-19 pandemic, and is a fellow of Interi, and is currently conducting a research project on how to improve health and well-being of older persons in the primary care level. So Dr. Geffen, we're very delighted to have you, and we're looking forward very much to your presentation.
Chris, thank you very much for the invitation to participate, and thank you, and great honor to follow Anja and Graziano. And I'd just like to get my PowerPoint presentation to share with you. Hopefully this will be working. There we are.
Great. Yeah.
Right. Can you see my slideshow? Oops. Messed that one up. Now I'm on speaker. Oops, sorry. There we are. No, I'm not. Okay. Well, sorry. Somehow or other, let's just try and move forward. Okay. I have. Excuse me. Let me restart my slideshow.
It looked like it was including closed captions there when you were
It did.
presenting.
There we are. I'm going to have to cut. I'm going to have to stop this. Excuse me for my Luddite presentation. My Luddite. Right, there we are. I think that should work. So South Africa is a country of just under 57 million people. Can you see my slides now?
No, we're not able to see them right at the moment.
You're not able to see them. Oh, goodness gracious. Let me try and get this share. There we are. Are you seeing that?
Looks great. Thank you, Leon.
Okay, thanks. Thanks, Chris. So we're a country of 59 million people. Sorry, 57 million people. About 9.4% of our population is over the age of 60. And the data that I'm showing you here in the bottom right corner is data from our 2011 census in terms of what people reported in terms of ADL impairment. About 4% of people reported difficulty having stairs. And as I said, this is from the 2011 census. Our next census is due this year in 2021. It's every 10 years. But we're not sure whether this is going to go ahead because of the COVID pandemic. And quite frighteningly, 73% of the older population live on around about $100 a month. The COVID pandemic has obviously affected South Africa in much the same way as it affected every other country, and in some cases quite a lot worse. To date, as of this morning's report, we've had about 1.5 million cases confirmed in the country, of which there are 52,000, just under 52,200 deaths. But I'll come back to the death number, the number of deaths reported in a moment, because it's very important to be able to understand that the total number of deaths reported over here is from in-hospital deaths in South Africa. This is not about community-based deaths, and much the same as and really thanks to Graziano, who's brought to the forum today the issue around excess mortality. And our excess mortality calculated to about the 13th of March is about just under 150,000 people. And this is taking into account the fact that we had no flu epidemic last year, the fact that and South Africa is a country with high levels of mortality due to violence and road traffic accidents. And during the lockdowns that we've gone through so far, the number of deaths due to alcohol-related injuries, road traffic accidents, and homicide are well below that which has been previously reported. So this excess death rate, or excess total number of deaths, is only explained really by the COVID pandemic. And if we look at what our RT value, the reproductive value in terms of how COVID is getting into an exponential phase, in our first wave, which happened March, April, May last year, we saw the RT value remaining consistently above 1. And then with the lockdown measures for a considerable period of through August through to about early December last year, we got below that level. Then we hit our second wave and had stringent lockdowns again in the December-January period, got our RT level below 0.5, and now we see that we're creeping back up to 1. And no doubt within, I would imagine, the next 4 to 6 weeks, we will see our third wave of COVID, probably after the Easter weekend, unless there are stricter controls brought in that will prohibit people from socializing and participating in social activities. But no doubt we will see our RT value climbing well above 1 again to see an exponential growth in the total number of cases in the country. Anja, thank you for highlighting the issues that you've got in Belgium, and it's interesting to see that the problems that we're having with our vaccinations are not unique to South Africa, but to date, we have only vaccinated 182,000 people. We are using the Johnson & Johnson single vaccine. Only healthcare personnel have been vaccinated to date. And it is planned that in the second wave of vaccinations, vulnerable older people living in care facilities will be vaccinated. However, we haven't been given any guidance by the government or any of the leading vaccination company organizations or the NGOs that are very involved in this and the National Institute of Communicable Diseases as to how the vaccines are going to be rolled out. And as Anja mentioned, are we going to have to take people who are living in care homes who may be very vulnerable into a vaccination center, or will we be able to vaccinate them in their facilities? If we carry on at the rate that's happened since we started vaccinating about 6 weeks ago, we will take 17 years to vaccinate the whole population. Our excess mortality rate is shown in a couple of these curves over here, where we can see the various waves that we've had and how we can see the excess mortality. The upper bound stippled line, as Graziano mentioned, excess mortality is measured much the same way as the preceding 3 years of normal deaths or deaths that have occurred in the country. And this is all-cause mortality for 1+ years. And this is the all-cause mortality for the 60+ years. And you can certainly see we are well above the upper bound levels for our all-cause mortality. And it's all explained by COVID. There is no further explanation. If we look at our excess deaths over here, the top of the blue peak over there is the excess deaths that have been reported, and then the orange or the little red peaks over there is the reported COVID death. And you can see that there's a significant difference between that which has been reported and that which is being calculated through our Medical Research Council, coming to a figure of close to 150,000 excess deaths in the country. Mortality data is reported through the National Institute of Communicable Diseases, and when they are reporting the total number of deaths in this country, they are only reporting hospital-related deaths. And what we can see over here is that our significant number, more than 60% of all deaths, have occurred in people aged 60. But I'd like to focus a little bit for this talk on our macroeconomic consequences of what COVID has done, and how in a low or in a middle-income country in the global south, the massive impact that this is going to have on our future development and no doubt on the well-being of older persons. So as of the end of second quarter last year, which is June 2020, there'd been a decrease of 11.3%, or 82 billion rand, relating to Canadian dollars, about just over 8 billion, just under $8 billion of salaries paid or earnings declared for that period. So a significant decrease in the total amount of income being paid to workers in the country. With that, it's reflected in this loss of jobs. And we have the number of jobs from quarter one 2020 to quarter two 2020, we saw a shedding of over 600,000 jobs. And that takes us back to the last quarter of 2015. And clearly we know that the moment we see South Africa has not grown as it should have been economically, we are entering a recession, and this is obviously a major problem that we are faced with. The South African government has released about $30 billion to support health and frontline services, protect the most vulnerable, drive job creation. And they've taken a further loan of $4.3 billion from the IMF. However, those are going to come with significant structural adjustment programs, as IMF loans generally do, and will significantly impact on future growth within the country. Anja, in her talk, alluded to the various silos that exist, and South Africa is in a similar position, that our care of older persons falls between two departments, the Department of Health and the Department of Social Development, or for some countries known as the Department of Welfare. Department of Health has a provincial mandate. Therefore, each province has its right to set its own targets and its own budgets, and then obviously get the budget from the central government. The focus from the Department of Health is on the prevention of illness and the promotion of healthy lifestyle. Their main programs prior to COVID were management of non-communicable diseases such as diabetes, hypertension, COPD, management of infectious diseases, and particularly in South Africa, HIV and TB, which have got a very high prevalence, child and maternal health, and on trauma. Older persons do not feature in any of the main programs. In fact, the older person program falls under the non-communicable diseases program, where the Department of Health is putting out a statement almost to the point that growing older is equivalent to a non-communicable disease. The Department of Social Development is a nationally mandated department, and they're involved with social security and social assistance, care of older persons in care facilities, and all care facilities fall under social development and not under the Department of Health. And they're responsible for providing old age pensions, disability grants, and providing some sort of long-term care services and poverty reduction. Old age grants are provided by the Department of Social Development. It's a non-contributory means-tested pension for all people over the age of 60, or for people over the age of 60, and the current grant is about 1,800 Rand per month, which translates to about $110 per month. Currently, about 3.6 million people of our just over 4.5 million older people get old age grants. But old age grants are very, very important in intergenerational families, multi-generational families, where they are used to support unemployed household members, grandchildren, and it certainly goes a long way to reducing poverty in the most vulnerable communities. But of the money that is paid to the older person, a very small percentage of that actually goes to their needs themselves. There is no long-term care insurance to finance any ADL support in the community in South Africa. Long-term care services, the institutional care in terms of long-term care facilities, it's mostly in 2 of the 9 provinces. Funding is per capita based, it's not facility based. Thus, if a facility has lost a significant number of its residents because of things like COVID or the lack of admission to the facilities, particularly during COVID last year, and then natural attrition because of the normal mortality that we would expect in these facilities, and they're not able to bring new residents in, the funding gets reduced proportionally to the number of residents who get reduced, which means from a staffing perspective, it's very difficult for care facilities to plan for staffing, and they often have to outsource all their staffing so that they can actually manage the pool of carers appropriately. And it makes these facilities very vulnerable in terms of the lack of funding to support infrastructure within the facilities and various programs that the facilities would like to run. In terms of home-based care, there's no nationwide services for home-based care. It's very limited, and most of the service delivery is via the NGOs or community-based organizations that exist. And once again, it is a per capita funding model for this. In South Africa, we have about 0.4 long-term care workers per 100 persons over the age of 65, well below the norm for higher income or the OECD countries, and only 0.2% of our GDP is spent on long-term care services. There's a significant lack of data on the number of people receiving either informal or formal long-term care, the number of people living in long-term care facilities. One of the positive outcomes from COVID is that the Department of Social Development has rapidly had to go out and identify all care facilities and know who is living in them and how many people are living in them. We don't have any data on the number of formal care workers, and we also don't have any real idea within the community of people who will ultimately need long-term care. One of the things that the program for today and tomorrow is a little bit about innovation, and one of the things that I think we've learned from COVID is that innovation doesn't have to be expensive. Making use of technology makes a difference, and we don't need to have high cost measures to make an impact on the well-being. Two of the programs that were implemented in the province in which I'm living was one of which is called this virtual emergency care tactical operation, where there was an intervention to target all diabetics in the province receiving care. And in a small study done in diabetics, they had a 28% mortality, and merely just using phone calls, reminders to people and getting chronic disease the medication delivered to them, and ensuring people were adhering to their diabetes program, they reduced the total mortality from 28% due to COVID down to a 4.5% mortality. A significant change over there. Most older persons and people receiving chronic diseases at a primary care level in South Africa would have to go into acute care, primary care clinics to receive their medication. However, we have a well-established community-oriented primary care model, and community health workers in our province, the Western Cape, are involved in providing care and support services to do things like vaccinations, weight and growth charts for infants, advising mothers on breastfeeding programs, the TB DOTS program, and very rapidly making use of Uber, as well as quite some funding from the Gates Foundation. Community health workers rapidly were trained in terms of getting patients medications from a central dispensing unit to over 200,000 patients per month, where those patients would have had to go into the acute care facilities to collect their medication. Some very simple, innovative models working together with the private sector, such as Uber, and then so a wonderful example of a public-private partnership. Really, just to conclude, ultimately, from the macroeconomic perspective of our country, we have to ask who's going to pay and what's going to be the outcomes of COVID. And we know that there's been a significant reduction in funding of services to older persons. There's no guarantee that the payment for service delivered to older persons through a lot of the programs from the Department of Social Development will continue. The programs that are being run by the community-based organizations, the non-profits and the faith-based organizations, is under severe threat. And that is all and the impact and the financial stability of long-term care facilities are all uncertain. So ultimately, older persons are going to suffer not only suffering from COVID and the high risk of dying from COVID, but post-COVID, and once we have got all our vaccinations in place, and hopefully by the end of 2021, maybe by end of first quarter 2022, we will have had 60 to 80% of our population vaccinated, including all older persons. But the financial cost that the country has had to bear through COVID will come for many, many decades, will be felt for many decades to come. So thank you very much, and thank you for the opportunity to be part of this wonderful forum.
Well, thank you very much, Leon. And Graziano and Anja as well. It's a real honor to be moderating this session with all of you doing such amazing work. We have a few minutes remaining for discussion before there's a scheduled break at 2:20 to prepare for the changeover. So I wanted to start maybe with a question that came through from the audience prior to today, and it's sort of like a crystal ball question, and all of you have alluded to sort of what needs to happen in the future, what the opportunities arise, the potential positives that can come out of this, which is great. But I wonder, you know, what's the one thing we should all be thinking about and working upon that maybe we aren't? In other words, you know, is our focus shifted in one way, you know, too much on certain aspects of this issue, and we're missing out on something else? Or, you know, do we feel we have all these bases covered for how we're thinking about this issue in the future? Easy question, I know.
Yeah, really easy. If I may, Chris, I think we should be more aware of the fact that we need good advanced care planning for people in nursing homes or vulnerable people, older people in general. Because one of the problems I encountered was that they didn't have that kind of talk, and certainly didn't have a more detailed kind of talk. Maybe just do not resuscitate, but that's not enough. You need to know what people, even if they can't express themselves that well anymore, what they would have liked, whether they would have wanted to go into an ICU or not, whether they wanted to be very safe or see their family, etc. And for many people here in Belgium, they didn't know, which put pressure on families and staff because they had to make decisions for somebody else without knowing whether they made the right decision. And on the other hand, also kind of highlights that, or even stresses more that older people cannot decide for themselves. Well, they should be able to decide for themselves. And I think I think one of the lessons we need to learn, there are many, but one of the lessons to be learned is advanced care planning, and start with it early on.
If I may, it's a very hard question. I mean, a single thing is very difficult to identify. I mean, for us in Italy, it's definitely a great opportunity for reshaping the system and having a more organized and integrated care, which is not the case right now. So I would say that improving the connection and the link among different actors within the healthcare system is really what we have to learn from this experience, and what can really improve the care of older people. Again, we have right now a great opportunity of reshaping the systems. The public opinion is pushing toward, at least in my country, toward an improvement of the healthcare system, and I think it's really, there are money to do that, because in Europe we have some large funding for these new opportunities. So I think it will be a challenge in the future, but it's really feasible, and the integration of all actors and sectors of the national system is mandatory, at least in Italy.
Chris, if you had to ask me what is the single most important thing, I think the most important thing that we've learned from COVID is that it's a global disease, and no country has been unaffected, and no country can manage this disease on its own. And I think it's vitally important that we need to start supporting global institutions, that there needs to be global responses to global problems, that this cannot be tackled on a national level. It's a transnational problem, and from all aspects, the economic aspects, how things are funded, through to supply of PPE, through to supply of expertise. As the disease goes through its various waves, we could have taken experts from various fields, people who are expert in Italy or in Belgium who've been through the first wave. We could have translocated them into other parts of the world if we had decent and proper transnational and global institutions that allowed this. Maybe I'm too radical in my thinking about this, but I truly believe that we have to start strengthening global institutions to tackle global problems.
Yes, thank you, Leon. I mean, that makes so much sense. And at the same time, you know, you're in your presentation, it's outlining the true dire circumstances that a country like South Africa could potentially face from an economic standpoint, which is certainly going to affect, you know, individuals of all ages. And if we become too sort of individualistic in our views of how we tackle these problems, it's going to be very dire. So I think that's a good place for us to end. I would like to continue the conversation, but unfortunately we're out of time and we need to move to break. So if possible, maybe I can, if a few more questions come through, I can send them through to our guest speakers, and they're welcome to provide their input as needed. But I just wanted to thank all of you for taking the time to present, and I believe Lily will take us to break.
I didn't really need to say anything, but yeah, thank you so much. Really enjoyed your talks and learning lots. What a wonderful way to start this symposium. Enjoy your break. See you back in 10 minutes.
Thank you.
Thank you very
Thanks.
much.
Yeah,
Thank you.
I think, Trevor, are we offline now?